So what we've got now, Professor Vogel isn't able, as you know, I'm sure most of you heard yesterday, but is anybody that doesn't know that Professor Vogel, isn't coming? Okay, so basically Professor Vogel's son is very sick and in hospital, and it's been a bit, he's been telling us he'll come if he can, but he'll organise, he'll do his best to organise, if he can't come, something instead. So what we've got what he sent us is a video, and he's really sorry. He's really sorry, and I know he really wanted to come. So it is really sad that he hasn't come. He's a lovely man as well. So he's very cooperative and lovely. So I'm thinking we can maybe set something up so that we can get to do some video conferencing or something. You know, let's set something up. Well, Sidika, the expert, will maybe help us do that. There she is. So anyway, we're going to do that, and then we're going to have a longer break. So just to give you a chance to, breaks never seem to be long enough. So we're going to have a slightly longer break, and then when we come back, we're going to do a bit of sharing, bit of connecting, sharing. And don't think I need to tell you anything else. We've got Rosie Daniels later on, and we've got a great day. We've got great workshops in store for you as well, so, and lovely lunches again, of course. So, okay, so we've got the video. Is that all right? Are we ready?
Yeah, ladies and gentlemen, dear Fiona, dear Patricia, first of all, thanks for inviting me to that conference. I'm extremely sorry that I personally was not able to manage because of a private illness in my family, allowing me not to stay a longer time abroad. First of all, also I say welcome to all my patients there. I know that there are several patients who trust also in treatment methods we do here in Frankfurt, and I extremely honor and favor this aspect of international treatment. My topic is today the role of interventional oncology in the treatment of cancer and metastasis. And in the following slides, I want to show with you the new field in oncology. I'm also thankful to a lot of people who help the patients to find the way to Frankfurt, to find the way to treatments. Now, first of all, the facts about metastases. Metastases are the most common tumors, especially in the liver, but also in the lung. The adenocarcinomas are the largest group of metastases in an area of about 65.5%. Neuroendocrine carcinomas are the second largest group with 16% of liver metastases. This slide is very crowded, but it shows you where is the current concept. You know, if a patient has liver metastasis of a primary cancer, like in the bowel or in the breast or from some other areas, first of all, there will be always discussed surgical therapies. In surgery, they can do either resection or ablation. In oncology, the patient will be referred either to a systemic chemotherapy, to immune therapy, or possibly also to a regional chemotherapy. In interventional oncology, we have a bunch of methods where we can either use interventions like laser, radiofrequency, microwave, or cryotherapy. We can use chemicals like localized cytostatic agents, alcohol, acetoxide, exit, stereotactic radiotherapy, or we can also use transarterial chemoembolization, radioembolization, chemosaturation, or focused ultrasound. This is a scarring which is normally a result of a lot of different methods. And of course, for the patient, it might be interesting to use the methods to destroy tumors where no big surgery is necessary. But I have to emphasize that the treatment nowadays mainly consists of a combination of both treatments. First of all, let's go to thermotherapy. Thermotherapy, you know it also as hyperthermia, means the thermal destruction of tumor tissue. This can be done either by laser, radiofrequency, microwave, focused ultrasound. Mostly we treat patients in unresectable situations or metastases. The whole treatment can be done in local anesthesia or in sedation. Normally, it takes us a short hospital stay, and it's a multimodal tumor treatment. Let us look at the different methods, and we have a long history in using chemotherapy, like Hippocrates. He started, and he has a statement which is still valid, that diseases that medicines not cure are normally cured by the knife. Those that the knife does not cure are cured by fire. And he stated that if something cannot be cured by fire, it has to be considered incurable. And in some ways, it is still valid. Okay, so we are now in the different methods. On the left side, you see the penguin, the cryotherapy. We are treating tumors by cooling. This is mainly done in the kidney, can sometimes be done in the prostate. In the liver, mainly we do radiofrequency ablation, RFA, microwave ablation, MBA, laser, electroporation, transarterial chemoembolization. So a bunch of different methods. And interestingly, all these methods can be done either non-invasively, interventional, or it can be done open surgical. Here in the following, you see a video which was done in order to show you how such an intervention is done. The example is a patient with a liver metastasis. He's treated by laser ablation. And you see here the liver itself, you see the gallbladder, and now what happens? We have a central tumor. Surgeons don't like these central tumors. They have to resect a bunch of liver, so we go with a catheter in. First of all, we penetrate the tumor. Then via the sheath, we go in with our laser fiber. We position the laser fiber centrally, and then we start the thermotherapy. You see the signal loss, the heating, is then visualized. So we can use imaging like CT or MRI as non-invasive measurements of the temperature. At the very end, we retract everything. We also treat the needle tract so that no tumor cells are coming out. And after treatment, over the time, the lesion itself disappears, there remains some scarring, and we get it all fixed. Example, patient 3 times operated on the liver, a new liver metastasis. A very delicate situation in the dome of the liver. We go in with 4 laser fibers. They are positioned here, you see them here and here. And then what we see is that we have, before laser, we can directly see the inserted laser fibers. And here you see the fiber structures which are coming along here. And you can exactly visualize now and come to any part of the liver or in the lung or in other tumors. And now we are using the MR unit as a non-invasive temperature measurement system. You see the signal loss coming 5 minutes, 9 minutes, and then 22 minutes. And you see what's happening. We have the temperature loss much larger than the initial tumor, and leading here to complete destruction of the tumor, but still the vessels are open. What is important? We need a safety margin for any type of metastasis. It makes no sense to only partially treat the tumor. We have to really completely visualize the necrosis, which is shown here nicely. Can everybody do that in a way? Yes. Tumor ablation, of course, it depends on the best technology available. It depends, secondly, on the operator. He should have a lot of experience. And he has to understand the biology of the tumor. And in between all these circles, we see the optimal ablation as a goal. The key question is, if we perform ablation and not do surgery, we have to do an R0 ablation. We need a complete ablation to have a complete response. Here an example. We have a patient with a big liver metastasis, highly vascular, a lot of vessels, smaller metastases. So the smaller metastases here, we treat with laser, RFA, or microwave. The bigger tumor, we first have to downsize. So we go in with a catheter, position a balloon, we are injecting drugs in order to make the metastasis smaller. This can be either TACE, can be SIRT, or can be chemosaturation. So quite easy. Let's start with the colorectal cancer. It's the third most killer in cancer in the world. And 50% of all patients with colorectal cancer will once develop liver metastasis. And 85% initially are already ineligible to surgery, so they need extensive treatments. Here an example of a 57-year-old patient. He showed up in my department in July 2001, and he decided that, okay, he wants to do systemic chemotherapy. You see what happened, the tumor is growing, it's invading the vessel, and you see multiple new tumors, so the total tumor was exploding. So maybe just doing systemic chemotherapy maybe was not the right decision in this patient. How is the efficiency? How is the literature? And in focal hepatic therapy for metastasis of colorectal cancer, still we are looking for good studies. You see good quality in 15 studies, fair quality in 12, poor quality in 3. In conclusion, you can say that currently local treatments are possible. They can be done, but still a lot of studies have to be performed, and also my institution in Frankfurt is doing a bunch of studies in order to prove that. So looking at the colorectal liver metastasis, you see resectable, they go to surgery, but they can also go to thermal ablation, and they do it more and more. The bigger tumor, the many tumors, they get systemic or local chemotherapy or embolization. What is a checklist? If a patient says, okay, maybe possible interest in performing interventional oncology treatment, first of all, we look in the liver. The same is valid for the lung. Are there one side or both sides of the liver? Is it resectable or non-resectable? Came it initially with the cancer or later? And do we have extrahepatic manifestations like tumor in the peritoneum, in lymph nodes, lung or bone tumors? And I think for you, and I know that a lot of you and patients are there, the question is also, are they symptomatic or are the patients asymptomatic? Here, our classification. So we have the patient with one liver metastasis, resectable. Mostly they undergo surgery or laser ablation. They are potentially resectable. We make the tumor smaller. And these patients with many tumors on both sides of the liver, they will become never resectable. The literature about liver resection is even incomplete. It's not conclusive. We have not data proving that this is now really the life expanding. What are prognostic factors? How many tumors we have, the mean volume of the tumor, the location of the primary tumor. So you see a bunch of factors. We also analyzed in our huge patient collective and published it in 2013 in the journal Investigative Radiology. Example. Patient was treated here with liver metastasis. We inserted the laser fibers, and we see a huge necrosis. We have a safety margin we have to treat. And then here, some months later, you see the residual tumor is still scarring. No new activity is visualized. And here we would say this is an RC ablation. You see the volume after ablation. It starts, it goes lower. And even after 36 months, you can see the lesions. So don't be pessimistic if you then do ultrasound and suddenly you see lesions. That's completely normal. There's nothing which should not be there. The gold standard, or what has to be considered always, is the survival. And if you look here in our survival data, patients, resectable patients we treated with laser, they are like liver resection after 6 years, live about 60% of the patient has a good role. If the patient are palliative, they die earlier. You see the curves which come straight down and go very low. And this shows that the cancer is still active. Data, LITT and others, here data on more than 600 patients, major complications, not relevant, smaller complications. We have seen also the same is valid for the other groups. Radiofrequency ablation of the liver. You see here the data are a little more inconsistent, a little more incomplete, but they show again that here good survival data is also possible. But still, data are missing. And here's a clock trial which is done in Germany and also in UK, and it compares radiofrequency and chemotherapy and resection. And we have seen some good response after randomization. And these are the first data which have been published, and we are waiting for the next patient and studies. For the local chemotherapy treatment, which we do very frequently, it's important to have a 3D view. Here you see the catheter in the liver artery. You see many of the small tumors which are nicely visualized in 3D, any planes. This is our working horse, our gold standard. And we can analyze the perfusion. And you see the more in perfusion in the right liver lobe, which is nicely demonstrated here. And what is the problem? You see that in the MRI, we only see these 3 tumors, but if you look at the perfusion, you know suddenly, oh, the whole segments of the liver are involved. So it might be that what we just see in the MRI is only the top of the iceberg, and the underlying tumor cells are also in other parts of the liver, making these images clear. After successful regional treatment, complete loss of the hypervascularization, complete loss of the density, extremely good results, which are visualized here. We treated about more than 560 patients now with local chemotherapy and embolization, different protocols. You can easily forget this is a task of the radiologist. But what is a result? The overall survival, you see after 3 years, there are only 7% are still alive. So we have to improve this curve from this very low level here to a curve much higher in order to prove our therapy. Some examples, here a patient with a huge liver metastasis. Before we embolize the tumor, you see the vascularization, and you see what happens. After the first stage, the tumor is already becoming smaller, less aggressive, here significantly smaller. And now it starts a problem. To do operation now, it's small, or to do resection, here we decided to perform laser and microwave, and you see a nice devascularization, complete local oats control. And these are again the curves, progressive disease, partial response, and subtle disease. Important is the question neoadjuvant chemotherapy. Should we first do a chemotherapy and then treat the patient? Those data are still unclear. The chemotherapy means a lot of vascular injury, a lot of steatohepatitis, and so we have to be very careful on this. A new study we are currently performing is to first do TACE and then LIT, which is shown here, and the diameter shows and the data that we have an overall local tumor control of 13 months, so we have a good mean survival, and we are improving our data. This is also valid for the microwave ablation survival rate after 1 year. 82% lower for the other groups, so still on a good way. Advantage of microwave ablation is clear. It's faster, we have higher intratumoral temperatures, more clearly delineated ablation zone, simultaneous ablation to reduce procedural pain. So our mean follow-up here was 32.5 months with significant result. How does it look? Before microwave ablation, CT-guided microwave ablation, we have to adapt our needle to the complex anatomy here. And the night, therefore, was quite short because we have been a lot of bunch working in order to bring our probe here. But you see here is the probe. And you see what's happening. Around the probe is a vaporization of the tissue. So we are completely now destructing the tumor with a very good result. It's shown here 24 hours post-microwave, 1 hour post-microwave. You see a complete normalization of the liver tissue with an extremely good result, which is shown here, this patient. Before therapy, after 3 cycles of chemotherapy, you see again increase in the size, better demarcation of the lesions, and so thus improving the topic. Major complications, only in 1.1% published. Smaller mortalities are also observed, and overall survival 82, 61, and 51%. In conclusion, we currently could say that for thermal ablation, microwave is safe, laser is maybe the best, RFA is possible. A tumor size of equal to or lower than 3 centimeters is standard. Higher than 3 centimeters, you need a lot of experience. The chemotherapy is also a significant prognostic factor, and also interval therapy. My end also goes to new therapies like chemosaturation. We clear the blood from the melphalan here in the chemosaturation, which is now shown here, new technology fascinating. Let me summarize. Colorectal liver metastasis, large volume metastasis, we resect, smaller one, we ablate, microwave laser RFA, and in some of the tumors we also resect, typically resections or alternative treatments via laser or RFA. For the extrahepatic manifestation, there are many things to do. Again, the slide, confusing, but it shows resectable or irresectable. We are coming to liver-dominant metastasis, but you see more or less it's the only goal is to keep the liver working in order to prove the whole concept. And this brings me also to My third line strategy, roll of 5, up to 5 numbers, up to 5 centimeters. We can do a lot of interventional things. Larger than 5 centimeters, it becomes more and more problematic, or if the tumors are just too many. So let me end and summarize. Again, thank you for giving me the opportunity to present you the data. Hopefully I didn't confuse you too much. If you have any questions, or you always feel free to contact me. Fiona has my email, Patricia has my email.
Yeah, obviously that was quite technical in many respects. So I thought, as I'm very familiar with his work, and there are hands up here who's been to Professor Vogel. There's quite a few here yesterday, weren't there? 1, 2, 3. I've got a lot of my clients who he's helped tremendously. It is a very targeted therapy. It deals with a problem in an area, but when you're looking at things holistically, that can actually be a very good thing to take it out. So, and what, what are your questions from his presentation? Yeah. No, he does do things that are bigger than 5 centimeters. His greatest success, and you find this with most ablation techniques. The word ablation means to basically, if you get to a tumor and zap it with something. Now, in oncology, this is the big difference between systemic chemotherapy, which goes around the body and is, by the time it hits the target area, it's pretty watered down, but it's caused a lot of peripheral collateral damage on the way. So ablation means if you get next to a tumor, it's actually not difficult to affect it because you can zap it with something, whether it be microwave, radiofrequency, heat, cold, chemotherapy. There's all sorts of different ways. Lower than, mainly in this country where we do have radiofrequency ablation for the livers, they won't treat over 5 centimeters. What is being developed mainly, again, in other countries, is techniques whereby they will tackle that. It takes him longer to shrink tumors. And over 5 centimeters, the larger the tumor, the bigger the blood supply. But Professor Vogel has so many different techniques. One of his main techniques is to actually access the main blood supply going into the tumor and inject it directly with chemotherapy. Obviously, because it's directly in that area, it's a high concentration of chemotherapy compared to what you get if you use systemic. And he then creates a chemical embolus which seals it in. And that dissipates over about 3 days. And by the time it does, most chemotherapy's half-life starts off at about 6 hours, depending on the drug, up to sort of about 12, 14 hours. So by the time it dissipates around the body, you don't get that collateral fallout of the person being very unwell. So you get greater effect and less collateral fallout. It works very well in an integrative program. And interestingly, Professor Vogel, lovely, lovely man. Those who know him, he's in person a man of few words. But what he says normally comes across a great meaning. He now refers people for hypothermia treatments, and he now refers people on and recommends they have a more integrated program. He summarized that very well one day. He said to me, this integration, it's very good. That's all he needed to say. We've got it now, so. So it's in my work, I find this as there are times when cancer needs a bit of a knock on the head. We need to take the momentum out of it. We need to allow the opportunity arise for all the work that we do with our bodies and everything else to take place. And compared to, as those of you who've experienced it, and in this country, it's systemic chemo, systemic chemo, systemic chemo. And that's, we do have some of these things available, but getting to them, getting our doctors aware of accessing them, etc. And very often, I find myself saying to oncologists, we don't want to tackle it systemically. We don't want that insidious fallout. We don't want that fatigue and the dragging down of the liver toxicity going on. We do want that area zapped so the person can have an integrative program and come and bring themselves into the fight. And so far, obviously, that argument doesn't go anywhere, unfortunately. But in Europe and in several other places, this is available. So, more questions? So, gentleman right at the back.
What do you think the effect will be of the medical innovation bill before Parliament at the moment, hoping to make it possible for creativity?
Did everyone hear that? What's the effect of the medical innovation bill? What the gentleman's talking about is a review where Lord Saatchi, was it Morris, the non-strangling one, I shouldn't say that, no, sorry. Of course. I was trying to avoid saying anything, and I couldn't. Oh, well. Is this being filmed? Oh, God, it is. Well, it's been a nice career. Yeah, Lord Saatchi is trying to get a bill through the House of Lords, the Medical Innovation Bill, to make our to allow our doctors to be more innovative, which is obviously something that's very welcomed. He had an experience about 3 years ago now of his wife being treated for ovarian cancer in the traditional way. And it was, as he found, and as an experience I witnessed when I was working on oncology wards, was the great shock of, oh my God, is this what they do? From the point of view, his wife, obviously, the success of treatment of ovarian cancer to this point has not been very good from the orthodox point of view. It's one of those where it's a very resistant cancer. The more you hit it with chemotherapy, the quicker it comes back. And it's a pretty difficult situation. And I've seen him interviewed a few times on this subject. And I found it refreshing to have somebody who's not like myself, who's bashing away at things. He was being interviewed on the BBC, and the BBC was saying, well, you know, obviously doctors don't want, you know, they're worried about people being safe and experimentation and that. I said, have you ever been on a chemotherapy ward? Have you? He said, it's barbaric. Have you seen what happens to people? And you can see the BBC interview going, oh my God. And he said, it's a failed experiment. Why are we repeating a failed experiment? You've never cured anybody with ovarian cancer. You've only ever made them ill. You've probably made their lives shorter, so why do they keep doing it? And it was just so brilliant to hear somebody say, yeah, go for him. Basically, he's going to say, look, the emperor has got no clothes. And he wants to change it. And the bill has picked up a lot of very popular support. There's petitions going around. I've been sending them all out to my mailing lists. And it's going to be heard in the House of Lords. Interesting question, how it's going to play out in reality, I don't know. We've so wrapped our doctors up in litigation. They're restricted on funding. You know, I was a manager in the NHS at one point until I realised that I would rather do anything else other than carry on with what I was doing. The fear factor of doing anything. I'm not quite sure that doctors want to be experimental yet. I think that's the transformation that's got to take place mentally. So, right, you know, you get people like Professor Vogel, fantastic, you know, he's found a way to do things better, and he's got on and do it. You ask a lot of doctors in this country, the clients I send to Professor Vogel, and they turn around and they say, he's a charlatan, it doesn't work, it's a lot of rubbish. You know, this paradox all the time. So there's a massive, massive sea of change that's got to take place in our doctors' mentality and the way that we allow them to do things, I think, before, you know, we see any great changes. But I got a fond feeling, especially with integration as well, that we are gathering momentum. And as we do, I think there's a lot of people waiting to jump out of the closet. I hope so. If not, we're all going to stand there looking pretty stupid. So, any more questions about Professor Vogel's? Yes, lady. Yes, there is. And as they gather data, obviously most of his work's done on metastatic disease because that's where most people go, so his data's all there. And like everybody else, he's trying to prove himself. Basically, if he can get to a tumor, he can take it out. So, and it's like with CyberKnife, things like primary lung tumors. I've had him treat a couple of people. And basically, I don't know if this came across in the way that he does it, actually, because I'm very familiar with it, but what he actually does is go in through the groin. So it's a bit like an angioplasty, and he goes up under CT MRI guidance, through the groin, threads up, accesses the tumor, because if you go through the blood system, you can get to just about anywhere because the tumor's going to have a blood supply. And he literally zaps the tumor with any of the techniques that he mentioned. So yes, a primary tumor, that can be used if you didn't want systemic or chemotherapy, radiotherapy. That could be used as a treatment for a primary tumor. Also, the context of this, for the experience people have when they go, it's a mix of being very, very high-tech, very, very simple, which I don't think comes across quite in the way that he does it. The whole process is done as an outpatient, and the whole process consists of going in the morning, having a CT scan, Professor Vogel going, yes, very good, we will do this, and the whole that really is it. The whole process takes about half an hour. Yeah, and then the person rests and goes home. It sometimes needs more than one treatment to get it done. It costs €4,000, and that's it. So for one treatment, yeah. No, he can access several at a time. Yeah, it depends. For example, if you've got metastases inside the lung, he will go into the lungs and he'll actually spray. If you've got, lung metastases tend to present as lots and lots and lots of little tumours around the lungs. If you've got a primary lung tumour, it tends to be one, sort of largish one. So what he'll do is he'll spray the inside of the lungs with chemotherapy. So he's getting to them all. In the peritoneum, he'll spray the whole peritoneum. I've had him treat rectal cancers, everything. It depends on how much needs doing. A lot of the time, because he's got very, very good CT imaging over there, he can identify which ones are the most pertinent tumours and which ones are the most active. And a lot of the time, he's not always necessarily clearing all the tumours out of the way, but he's downgrading them a lot and knocking the stuffing out of them, which then, of course, allows everything else to take place and go on. I've actually got one lady, Jane. She's had a hell of a journey. I've been working with her now for 12 years. And when she went, she was told her liver was pretty okay over here. She had microscopically hundreds of tiny tumours in the liver when she got there. So he treated her, and we're now 3 years on. We're still dealing with challenges that come up, but in that time, she's alive, she's well, she's got a good quality of life. Her doctors tried to write off against Christmas, she wouldn't have it. So here we are in June, and still doing great. So he's part of the jigsaw. He's not an answer, but he's a very good part of the jigsaw if it's needed. Yes, sorry. Yes. Yes, well, the question was, are you awake while he's doing this? Yes, you are. All it requires is local anaesthetic to the area. You can be given a mild sedative if you prefer. A lot of people like to watch what's going on. So it all depends. It's done at the University Hospital in Frankfurt, and the nursing staff are fabulous and very good. You get very well looked after. But but you can be given a mild. You can give them something like midazolam, which will sedate and make you drowsy without knocking you out. And those types of things have the benefit of they also act as an amnesiac, so you don't remember what's happened afterwards. So if he was very chatty, you don't even remember. Yes, Jessica. Yeah, sure, absolutely. Yeah, I did a bit on it yesterday. But CyberKnife is a treatment. We've got quite a few ablation techniques. The uptake of them is very, very poor by the doctors, which is a shame. And as I say, we can't get the argument across of just do that for us and we'll take care of the rest of the body. That's the real bit where we come down. CyberKnife is radiosurgery, whereby instead of using a big field of radiotherapy, a small field, a CyberKnife works precisely on an area, so it'll pick out a tumour. It's done externally, and the difference is, it came from gamma knife that you use for brain tumours. Now, with brain tumours, gamma knife's been very successful, but I hope nobody here's got a brain tumour. When you're doing something like that, somebody with a brain tumour, the difference is you literally bolt the head to the table so they can't move. So it's very safe and very precise. Now, you can't do that in the body because, obviously, we are breathing in and out. Our intestines are moving all over the place. And the difference with CyberKnife, the development, is actually the computer system. And it actually alters position 10 times per second. So it tracks the body and tracks the tumor. So you get almost like a knife effect of radiosurgery, eradicating precisely around the tumor with, again, minimal fallout to that. And as I said yesterday, we've got this in this country now for about 3 years. We've got about 4 or 5 centres around the country. The uptake by the NHS is 25% of its capacity because it's not being funded properly. So it's very hard to get onto. Even if you get referred sometimes, then the health authority refuses to fund it. It's very expensive. It's about £10,000 for a course of treatment or for a treatment. But, so this is why they keep coming back, systemic. It's quick, it's cheap, or cheaper. Hi. Well, the CyberKnife. They do require specialized teams, but the teams are there. They are. It's being used in the private sector a lot, but this capacity that's been allocated to the NHS, it's just not being funded. It's not being taken up. One of the reasons why you don't get, quite right about specialist teams, like Professor Vogel, why you don't get a widespread use of these sometimes is because you can put a drug into every hospital within a fortnight, and everyone can be doling it out without any specialism. When you've got specialized equipment and a specialized person doing it. I would say with the liver metastases, Southampton have started doing a clinical study on this, but they seem to be making a very big job of it. And it's not sort of quick and easy in the way that Vogel's doing it, but there is some interest taking place over here now. Sorry.
Is stereotactic radiotherapy, is that the same as cyber?
No, it's different. Oh, Saturday morning. Stereotactic, there's quite a few variations on radiotherapy, and stereotactic is a way of being more, they're all trying to find ways of being more direct and not hitting a big field, because the collateral damage from that and the fibrosis of the tissue is quite large. So stereotactic is a way of going in at different angles and bending it around angles, so you're not doing a big block, you're trying to get the tumour from all kind of different, it is a better than sort of standard radiotherapy. Hi.
We started having this conversation when I was lying flat out, and that was really all. But you know, it is a very they make it very easy for you. And I had lung metastases I have lung metastases from breast cancer, and I was having difficulty breathing and sitting up, and I was getting very frightened, and I didn't know what to do. And sometimes just getting as much information as you can from people helps you make the decision. So very happy if anyone wants to just have a chat. That was all really.
Yeah, quick one about NanoKnife. Again, another ablation technique. Gosh, we have lots of them. NanoKnife is using electrical impulses, and this is not done quite as externally, in that they have to put probes into where the tumours are and pass electrical stimulus down. But again, apart from a very, very thin probe being inserted, again, it's very precise, it's very effective, and they can cover quite a lot. And Professor Lean is pioneering that over here. Hopefully, we would like to say that there's going to be lots and lots of these availability of these things in the future, but we'll see. We'll see how it goes. But yep. Sorry. It's appropriate for liver. It's appropriate for lungs. Again, because it's in its early days, what they'll tend to do, like Professor Lean, because he's in England, he'll be concentrating mainly on those two areas because they've got to get the results in. They've got to crunch the numbers. But he's a little bit more, like Vogel, he's a little bit more experimental. So he's a very good chap. But Princess Grace Hospital. Thank you. Marylebone. Yep. Okay, thank you very much.